Good morning. I am thrilled to be here. I have gotten up essentially every day for the past 5-7 years thinking about integration of health and social services. And this is the first meeting I have ever been to, I think, that has that set of terms actually in the title. So it feels good to be among people who find value in this stuff. Let me find a keyboard. Okay. So what I'm going to do, and I think I have to admit, I just can't help but feel that my comments will feel a bit like navel-gazing after we've just heard such an important contribution from Marianne and Frank and Andy. But I think that my role is to be the navel-gazer here and to provide some overview in terms of the data that supports the need for additional attention paid to social determinants of health and social services. So that's what I'm going to do. I'm going to start with some data that I've been a part of producing at both the international, the national level on kind of how both countries and states allocate funding between healthcare and social services. I'll say a bit about what I think the research base really looks like in terms of programmatically which kinds of social investments seem to be both producing the greatest gains in health outcomes. Perhaps that's what we're most interested in. But of course, the academic literature seems quite preoccupied with which kinds of social services create the largest returns on investment. So I can say a bit about both of those things. And then the provocative part, I think, perhaps will be when I come to the policy comments. And I just have a few questions and concerns about what I'll call kind of the slug trail that we're on, meaning if we look back at what we've historically done around policies and we think about where that might be leading us, I think it's worth at least pausing and thinking about whether we need a course correction. So that's the rough outline of where we're headed. I'll start someplace that everyone hopefully feels fairly comfortable. This is a graph many of us in this room will have seen repeatedly. It's the percent of GDP, gross domestic product, spent on healthcare in the OECD countries. So OECD is Organization of, Economic Cooperation and Development. So you've got 34 countries in the OECD, United States being one of them, much of Western Europe with a few others thrown in. The US healthcare spending, as we all know, is incredibly high, somewhere around 18%. But the kind of paradox that Elizabeth Bradley and I were really trying to unravel when we wrote the book back in 2013 was not so much why is healthcare spending so high, but it was how could it be that healthcare spending is so high and yet our health outcomes, when you look on a population basis, do not seem to be keeping pace. So if you look at something like life expectancy, maternal mortality, and you look at the United States' rank in that OECD set, we're often at or near the bottom. And so that was the paradox. You know, one can think, if you want better health outcomes on a population level, you should invest in more healthcare. And yet that didn't seem to be panning out as a viable strategy. So the innovation of the book and what I've been working on since the book came out in 2013 is really this. What we did was we stacked social service spending for each of those OECD countries on top of the health service spending. So here again, your x-axis, you've got all the countries along the x-axis, you've got percent of GDP on the y-axis. Your blue bars are percent of GDP spent on healthcare, and your orange bars are percent of GDP spent on social services. What's in the social services? It's things like employment, housing, nutrition support, all the kind of traditional trappings of a welfare state. What you'll see is that if you look closely, the United States has moved into a middling position. So while we usually think about ourselves as this huge spender, you think about healthcare, the United States is at 18%, swamping everyone else. If we look, I think, more holistically at all the investments that a country is making to try and produce health for the population, which I would say includes the social service spend as well, the United States comes into something of a more middling position. So no longer are we the big spender, but we're not tiny either. And if we thought that just the total spending alone should be predictive of those health outcomes, well, that doesn't seem to be quite the story. But what you might notice is that the blue bar for the United States is larger than the orange bar, meaning that we spend more on healthcare than we do on social services. And I think this is kind of picking up on one of the themes from the story we heard about, the emergency service technicians were excellent. They were really high quality. They got there quickly. I think in some sense that's a metaphor for the way we think about creating health in the United States generally. If you're sick, we're ready to come in and rescue you with quick and in some sense efficient, it's probably going to be expensive, but really high quality care. But what we seem to do not so well, or not have quite as robust a strategy for, is kind of the preventative side, which I would consider those social services as really upstream prevention, trying to keep people from falling ill, and when they are ill, trying to support them the best way we can. So the last piece of this kind of very wonky data is that when we took a ratio of the blue bar to the orange bar, we found that that ratio was more predictive of a whole set of health outcomes in those OECD countries than the healthcare spending alone. So on the left here, you see the paper. On the right, the kind of key finding here is that the ratio of social health service spending was significantly associated with a host of health outcomes. And really, this was our way of trying to say, see, policymakers, we have to be thinking about beyond the hospital, beyond the clinic, beyond healthcare spending to these other domains of life and support in order to really be kind of taking on a fulsome strategy, a prudent strategy, maybe even a more cost-effective strategy to deliver on the promise of health outcomes for the United States. We went around and we talked a lot about that study, and of course the United States being what it is, people said, oh, we don't want to hear about England, we don't want to hear about Denmark, show us that this is true inside the United States. So what you're looking at here is this same kind of metric, the ratio of social to healthcare spending in the 50 states. It's a heat map where your kind of Kelly green are those states that most strongly prioritize social service spending in relation to health service spending. And your red states are those states that most strongly prioritize health service spending in comparison to social service spending. Unfortunately, this heat map, I think, looks a lot like basically every other heat map you'll ever see in a health policy or a public health class. So we have our hippy-dippy friends in the Pacific Northwest seemingly doing beautifully. We have a Bible Belt kind of area that seems to be challenged. And so this raises this important question, and I think an important critique and caveat to this work, which is that it's very difficult to disentangle what causes what. So is it the ratio of spending that really produces better health outcomes? Or if you have a very sick population, do they consume a lot of health care, meaning it forces your hand as a set of state legislators or policymakers, you have to spend more on health care. And really importantly, at the state level, you cannot run a deficit, and so the state policymakers' hands are tied. We're spending so much on Medicaid or we're spending so much on health care, period, that we no longer have the resources to really allocate that money to the upstream, more preventative social service supportive work that we would like to be doing. So there's always this kind of question about what's causing what, and I think, frankly, it's a vicious cycle. So the more you fail to prioritize in social service, the more you fail to allocate dollars to social services, you're going to wind up with a sicker population. A sicker population consumes a lot of healthcare dollars, and that functionally robs you as a state of being able to put the money where you might optimally want to put it. So this is what the ratios look like. I would just remind you again that my friends from Massachusetts, anytime I see this, hate this graphic. They think, oh my goodness, we're not in the middle or the bottom of anything related to health. But it's because it's a ratio. And so it's important to recognize that two states could have the same ratio with very different actual numbers in the numerator and denominator. And in a state like Massachusetts, frankly, we just have so many academic medical centers. We have so many doctors that our healthcare spend is quite large. And so it's almost as if there's no amount of spending on the social service side that we could do that would bump us much up, beyond maybe the yellow tier. Once again, we took this ratio and we plugged it into a series of models, trying to understand whether the ratio was predictive of a set of health outcomes. And we found, in fact, that it did. So this was a paper that was at a different level of analysis, but fully consistent with what we had initially found in the OECD analysis. Because it's the United States, we were able to do a whole bunch more outcomes and kind of play around with it. And we found things were sensitive to this ratio, such as people reporting 14 or more mentally unhealthy days or 14 or more days of activity limitations. So maybe particularly important to this crowd. So after doing those kind of studies, you will have heard me already say a lot about social services as a block. And we talked about social services as a block really because social service spending was to us a proxy measure. It was a proxy for kind of attention paid to social determinants of health or attention paid to social supports and services. It was an imperfect proxy. That's the nature of a proxy. It's not a bang-on measure, but it gives you some sense of where people's priorities lie. But when we talked a lot about social services, ultimately, and this was, I think, a sign of progress, people started to say, well, you've got to be more granular than that, Lauren. Which social services are really the ones that seem to be best researched and the ones that if I were sitting in a decision-making seat, I might most want to prioritize for the population. So we did a literature review asking the question that we thought was top of mind for policymakers and decision makers: which social services produce better health and save healthcare dollars? And I would say, Joanne has sensitized me to this importantly. I'm not sure that saving healthcare dollars is really the right metric by which we should be judging social service investments. And so, I put that out there and I can kind of leave it there. I'll return at the end, but I think that gets us into very dangerous territory. But that is the metric we use for this literature review, and so take these results kind of with that caveat in mind. Ultimately, three kind of domains of social service spending or social service programming kind of flushed out as the most evidence-based. Remember, this is a literature review, so you can't report that something works or doesn't work if it's not previously been studied and it's not already in the literature that you are reviewing. So this is also subject to all of the kind of bias that goes into how people select what kinds of things to study. But the three domains were housing, nutrition, and case management with home visitation. Housing has been quite well studied, in part because I think people who are homeless have posed a certain public nuisance, and people have felt that that was an important thing to try and get them off the streets because they were consuming a lot of resources, both in terms of ambulance, police resources, and then there's just been this kind of frequent flyer narrative of homeless people who are using a lot of emergency department services. So there has been quite a bit of work, even randomized control trials, trying to look at how effective it is, both from a health standpoint and from a return on investment standpoint of addressing homelessness by providing people housing or even supportive housing. The nutrition bucket is interesting because you have both the WIC program, which has been extensively studied and is shown to be producing returns in health, both to mom and baby, and be cost effective from the government standpoint. And then home delivered meals for older Americans, I think is just out of this park, studied, found to be a winner. I think it's a particularly interesting intervention. We put it in the nutrition bucket, but really I think it's a twofer, because as we learn more and more about social isolation and loneliness among older Americans, you've got to think that having someone who comes to the door, hopefully routinely, and says, "Hi, Mrs. Jennings, how's your day been? Here are your meals," is a kind of separate but important corollary to the actual delivery of a warm meal. And then case management. The case management literature is a nightmare. It makes my head hurt every time I go to it. But I think that what I did ultimately feel confident saying is that home visitation makes a difference. When people actually get to the home, they can just pick up a ton more information than you're ever going to get on one of these manifold forms that we ask people to sign up for. And so I think that really has pushed a certain part of the case management literature into both the improving health outcomes and in some cases reducing expenditure. I'll say this highlights the wrong problem in so much as the people who are making the investment in many of the social services are not necessarily the ones recouping the benefit. So let's think about a Meals on Wheels program. It's often funded by the AAA, the Area on Aging. Sometimes it's philanthropically funded. They make that investment. That investment creates returns to the healthcare sector, often in forms of reduced utilization. The healthcare sector, if they're in some kind of capitated contract, can really benefit from that and reap the savings. And one of the big open policy questions for all of the social services and determinants of health literature is, how do we balance that better? How do we make sure that if Meals on Wheels is making an investment or scaling up a program so that they can be producing health outcomes or reduce utilization that another entity is benefiting from, how do we make sure that that entity, say the health system or the managed care organization that's benefiting, then shares back some of those savings to the initial investor, which in this case would have been the Meals on Wheels program. So trying to track the differential effects and then really make sure that we're aligning the investments and benefits is just an open forever challenge for basically all the work I do. So I would say on the back of this, there have been a series of health policies, and by health policies, I mean national level, state level, even philanthropies like a Robert Wood Johnson that I think in many senses set the agenda for health policies that are trying to incentivize healthcare to now pay much more attention to social services or social determinants of health programming. I'll use those terms basically interchangeably. Nothing here is particularly important other than what I've just told you. The policies are moving to try and make sure that their healthcare organizations that are holding financial risk are really trying to work upstream to prevent people from getting ill in the first place, or keep them kind of in a stable state and not getting worse. Sorry. So I just want to give 3 quick examples. 6 Portland health providers, this is Portland, Oregon, our hippy-dippy friends in the Northwest, have actually put together a combined $21 million investment in new construction of 400 low-income or affordable housing units. Another is the Care More Health Plan. This is a for-profit managed care organization out in California, has actually stood up a loneliness intervention program, surveying all of their members for social isolation, and then standing up what's a pretty straightforward intervention of social workers, telephone calls. I think they're playing around now with some kind of pen pal systems, and then redesigning some of their brick and mortar clinics to be more friendly for people to come even when they don't necessarily have a healthcare appointment. And what they have found, anecdotally, I've talked to the CEO about this, he says something in the order of 15 to 20% reduction in healthcare utilization among these members who self-identified as socially isolated and then received this intervention. So to me, that's a mind-boggling number, just like a huge amount of savings from a fairly light touch intervention. But again, just illustrative of the theme of healthcare moving into social service programming. A third example is around transportation. This is not necessarily a healthcare organization in the sense of a clinic or a hospital doing this work, but this is just a brand new startup that's in Boston. It is, as it says at the top here, built for healthcare. Their prime customer that they built this whole startup in mind for were healthcare systems who are struggling with getting patients to and from appointments. So this is non-emergency medical transportation. And you can just see the way they're kind of marketing themselves here at the bottom. So offering a 70% cost savings, people get to their appointments on time, you get a reduction in missed appointments. And so this is a new transportation offering springing up in the community, marketing itself exclusively to healthcare, thinking that healthcare will want to get into the transportation game and basically purchase their services in some form of contract for their managed care or ACO enrollees. So here's what I think the open policy question is. It is, okay, if I have sold you even partly on the idea that we need to be putting more money in social services, transportation, housing, home-delivered meals, the question is, how do we want to fund those things? And I think there are 2 obvious options that if we were to just put up a schematic, we could think through. We could either fund them through the kind of traditional healthcare delivery system, which I think when I mentioned at the beginning the slug trail, this is the slug trail that we are on. We are recognizing this, we've woken up to the need to address things that historically medicine has not addressed, and we've said to ourselves, well, I guess we can just incentivize healthcare to do it and create new grants and new programs to try and explicitly call healthcare clinics and hospitals to do this kind of work. The other alternative is to not put this money into the healthcare system and ask the healthcare system to take on new roles and responsibilities and programming, but instead to put this money directly through the social service delivery system, which in fact does exist and is kind of an interesting combination of state services and then a whole bunch of usually nonprofit 501c3 community-based organizations. I think the reason that we have kind of defaulted to this idea of making policies that incentivize the healthcare system to grow its role and do the social service delivery is in part because it's very politically pragmatic. We think we have a highly responsive healthcare system. We've trained them to jump at all sorts of carrots and sticks. They didn't know anything about readmissions 15 years ago, and then we put money on readmissions, and now they do readmissions well. You know, there's a sense that we can just rejigger the incentives and they will be responsive. And I think, you know, no one wants to be seen, even our most kind of progressive legislators, policymakers, advocating for a larger welfare state. Just like no matter, if we're honest with ourselves, I just don't think people are out there saying, I want to grow the social service budget line in my state, or I want to grow the social service expenditure at the national level. And so funding it through healthcare is kind of a sneaky way to put money through a system. Healthcare is growing anyway. No one knows what's in the healthcare spend. And so kind of you're less likely to get called on it in some sense. Plus, many of the healthcare policymakers who I think are very well-intentioned simply don't even know what the social service delivery system looks like or how it would work to divert funds that way. So I just want to lay out as my last kind of minute ticks down here. I've said the slug trail, the kind of path it feels we're on is giving more money to healthcare to do this social service delivery. I have some concerns about how that would actually work. And my concerns are offered in the spirit of perhaps this is the pragmatic path and we just have to live with these concerns and caveats and be attentive to them and say, watch out where we step and try and manage them as best we can. But on the other hand, we should at least remain open to the fact that there are alternatives. There is a path out there where we don't continue to give money to healthcare and ask them to grow their role. We could be putting money in social services, and like I said, that was a rough schematic of two of the simplest options. So there may be other alternatives that we have not yet fully surfaced and investigated. What are my concerns? One is around valuation. If we let healthcare set the terms of what an investment in home-delivered meals is worth, it will always, in my mind, be a systematic underestimate of the value of that intervention. Because, of course, it's going to create some returns, potentially, to decrease utilization. But what is it worth? How do we value that person not being hungry or that person having that social intervention? That is never going to be captured in the kind of return on investment calculations that a health system or a managed care company does. And that's not necessarily their fault, but I think it's important to recognize that when we let healthcare set the terms of what social service investments are worth, it's an incomplete picture. A second concern is just around feasibility, and we've already seen some challenges with this. When we give money to healthcare and then we say, you go and maybe even contract, best case scenario, you go and contract with community-based organizations to actually do the direct service delivery, in many cases we've seen the money never gets out of the healthcare system. It's what I call trapped and vaporized. You give it to healthcare and then all of a sudden, oh, we lost it along the way. There were important things, there were emergencies we had to respond to, and it just never got done. This has totally been the experience of community-based organizations in New York as they have undergone a Medicaid redesign, and I fear that it will be the experience elsewhere. A third is just a set of efficiency concerns. If you're just thinking about contracts with my business school hat on, why would we try and route money that's ultimately trying to get to social service delivery, hopefully from community-based organizations, all the way through the labyrinth of healthcare delivery that we know is fragmented, and endure all those administrative costs, all those contracting costs, all those levels of overhead? It makes no sense. And the last is equity. There are always going to be some people for whom there is a return on investment that we can prove on these different types of social services, social determinants of health investments. But there will be other people on whom we cannot prove it. And those may be people right now who aren't in a capitated contract for some reason. Those may be people who are never on Medicaid or never on Medicare. They're undocumented. Those may be people who are not sick enough. They've not historically used enough healthcare services to bump into the high-need, high-cost group that you think you're really going to be able to create savings on. And so I just have real fears. I think the community-based organizations and social service spending ethos generally has been one of equity. And I think healthcare really runs on much more of a prioritarian ethic. You take people who you think you can save money on and they bump to the top, they get the services first. And in that, I am concerned about who gets left behind. I'm over time, so I'm going to break here and look forward to your questions. Thanks very much.